confident that the records that they have with us are accurate.
In terms of quality at EHA clinics and the level of quality that any patient expects to get, it's one of our core values. So, and one of the things that we monitor closely to ensure that when patients come in here, they're safe and that their care is reproducible.
We looked at the entire system of what it was going to take to deliver quality care, and we kind of built that from the ground up. So when we started EHA clinics, we even looked at the facility itself. You know, how do we actually get a proper facility that has things like air filtration built in the air so that as sick people come into the clinic, they're not spreading their illness to people sitting next to them. Quality is not an endpoint, it's a journey, and it's a constant journey. So you can't ever say, okay, well, we've reached quality, now we're okay. It has to be this continuous improvement. So we invested a lot of time and money in making sure our staff became certified by the WHO.
We want to ensure that we are implementing quality systems throughout our organization, right from our primary healthcare clinics through our pharmaceutical distribution, and every element of the business that we expand into. We are looking at development and opening new clinics in Abuja, in Lagos, and also in the East.
So what does the future hold for EHA clinics? The future of EHA clinics is really to access affordable, quality healthcare. If our dream came true, we would be in it. You know, we'd have at least 50 clinics, you know, in the next 5 years around Nigeria. We want to open up access to other parts of care, not just focus directly on the kind of primary outpatient care. We're looking at launching services to give people access to mental health, where that they can access their mental health and get counseling directly on their phone or on via a website. The minimum standard of care should be access, affordability, and quality.
I'm Dr. Ravi, Chief Innovation Officer of EHA Clinics. In this role, I lead our research and laboratory teams. EHA Clinics is a JCI and ISO accredited healthcare organization in Nigeria that is transforming primary healthcare. And research and innovation are an integral part of what we do at EHA Clinics, so we can improve the wellness of our patients and our communities. So I want to invite you to come watch my colleagues and listen to them as they describe the different devices and process innovation we have in our clinics.
The Oxford Nanopore Minion Sequencer is a next-generation sequencing equipment model which uses the nanoparticles technology to sequence multiple samples in a single barcoded mix and run. The equipment is portable and can produce about 50 gigabytes of data from a single flow cell. The nanopore sequencing is the only sequencing technology that enables real-time sequencing and in also a full-scale format. With this equipment, we are able to produce sequence of genome of infectious agents and can determine the strains and variants of these agents in a single biological sample.
Telemedicine bridges the gap between the doctors and the patient. It's a non-physical online consultation whereby the patient can access doctors' care and consultations at their fingertips. This could be done via the phone or via the system. Our patients can book for these consultations via our website at any day and any time.
This is a high breast scanner. It is used for breast scan and it can be used to detect pathological abnormalities that are found in the breast. It can also be used to detect lumps in the breast without the use of sound waves.
The IQ Butterfly is a point-of-care ultrasound device that is used for point-of-care ultrasound testing at EHA clinics. It provides images of patients' abdominopelvic scans as well as obstetric scans. It can also be used to measure fetal heart rates.
This is the ECG SmartHeart device. It is used in EHA clinics. It provides a non-invasive and convenient measurement of the heart's electrical activity. Now, the advantage of this is that you can send the results via mail to any doctor in any location, and it can be used in collaboration with the telemedicine kits to aid diagnosis in any location.
This is the RxL device. This device is used to measure the quality and the standard of drugs at EHA clinics. The drugs actually helps us to confirm that whatever drug we have is of top standard and of top quality, and it does this by measuring the active ingredients using a spectrophotometric method.
At EHA clinics, the near-infrared vein finder helps us to identify patient's vein without having to make several puncture attempts. The device poses no risk to the patient and also reduces turnaround time for phlebotomy.
Digital microscopy at EHA clinics helps us to transmit our images real time from the microscope to the screen. This helps for reproducibility and accuracy during demonstration to our students or the medical laboratory scientists when we train.
This is a killer non-contact tonometer. It helps in the diagnosis for glaucoma. It's actually non-invasive in the sense that it doesn't have to come in contact with the patient's eye.
Alethea machine is a molecular-based platform that produces results in less than 1 hour. It works on the principle of loop-mediated isothermal amplification system. Because Alethea produces results in less than 1 hour, it helps us respond to AR requests and confirm malaria species for treatment.
ISO 15189-2012 is considered superior over other global standards. It focuses on general requirements for the competence of testing and calibration laboratories. And finally, it takes into consideration specific requirements for quality patient care.
Everybody in the society benefits from our research in one way or another. So for example, for patients, we try to find answers beyond the typical malaria and typhoid that you see in Nigeria, right? When you go to a clinic, you're sick, you're told you have malaria and typhoid. We know that's not the case, so we look for answers beyond that. Right now we are doing a study on a disease called dengue, which is spread by mosquitoes, just like malaria, but can make you sick with fever. Students and young scientists benefit from our research because we offer them paid internships, we offer them free webinars, we offer them several training opportunities. And then for companies and universities, they benefit from the research because they can trust us to do research at the highest ethical and scientific standards. EHA Clinics recently formed an ethics review board that is going to be registered with the Nigerian National Health Research Ethics Committee. So we hope you will join us as partners and collaborators to bring more research and innovation to Nigeria.
Hello everyone, good evening. Welcome once again to EHA Clinics Academy. I think I can safely say Happy New Year because this is the first time we're having our webinars. Today we'll be looking at a very interesting topic, the challenges and advancement in blood transfusion services. We are privileged to have Dr. Olu Emmanuel Chinamso to do justice to this topic. So Dr. Chinamso also trained in Nigeria, is now working in the UK and has vast experience working in blood transfusion services, both as a lecturer, and as a laboratorian. I thought we'll be having a very quick time. We had some very productive interactions with him before this webinar, and then we're expecting a very interactive time this evening, a very good learning experience. And he has promised us that we're going to get to see if we're going to ask a lot of questions. The course, with a lot of experience, I know that resource persons are able to give out much more when we're able to ask them much more questions beyond what their slides can cover. Like you all, and like is our usual practice, you would have the privilege to access all the training materials, the recordings, and this video recording, and please, who is complaining that the voice is not clear? Okay.
So you can have the video recording, you can have the presentation slides, and of course you'll be given a certificate of attendance at the end of the process. Our housekeeping rules, please remember, until you're given the opportunity to speak, please do not interrupt. And from our end here, we'll be able to mute everybody. But of course, when you're required to speak, you can have the opportunity to speak. Dr. Emmanuel, good evening, sir. Can you put on your camera so that we can see? Hi, Dr. Emmanuel. Can you hear me?
Yeah, yes, I can hear you.
Can
Sorry, I
you
wasn't sure you
confirm?
guys are ready. Just give me a minute, please. Here we go. Okay. Happy days. Can you see me okay now, yeah?
Yes.
I'm not sure.
Yeah.
Okay. Yeah. You can see me.
Yes.
Okay, that's fine.
Yeah, everyone. So, Dr. Emmanuel, we're privileged to have you. I know it was not a very easy one to
Yes.
but we're glad you could oblige us the opportunity.
I hope you
like
guys
I
don't
said,
mind if I'm, yeah, I just need to finish up my tip or continue.
Yeah. So, like I said, we have the privilege of Dr. Bodo because he has practiced both in Nigeria and abroad. And I think the privilege is that he knows some of the limitations of practicing here in Nigeria and what are some of the advances that he has already witnessed and even advances that he is also going to witness in the blood transfusion services. So this will be the pluses that we can begin to look forward to better things. If there are policymakers amongst us, we can begin to make decisions to those who matter or decide, and then if we're just those who are learning, we can be looking forward to, suggesting even database discussions to our decision makers in our organization so that they can drive the process of bringing these advancements. In the long run, the goal is having a healthier patient, having a healthier society. Thank you, Dr. Obodo. I want to hand over the floor to you, and you can go on.
All right, thank you very much. I think we are going to start by, I just need to share my screen first.
Right.
Hopefully that will be of help. Let me know if you guys can see my screen, please. Thank you.
Yes, we can.
All right, that's fine. First of all, I would like to say thank you so much for attending this webinar. And I feel grateful to be invited to share some thoughts with you guys. Hopefully you are going to find this interesting. Right. So, just 1 minute. So today, just 1 minute. So today I want to first of all introduce myself. I know that you guys have heard a little thing about me. I would like this session to be interactive. So I'm going to start by saying that my name is Emmanuel Obodo. So as you can see from my qualification, you will see that I graduated in Nigeria. So I did my BSc in Nigeria, actually Imo State University. Then I did my MSc at University of Chester. Following that, I completed my PhD at the same University of Chester. I'm currently HCPC registered and also a fellow member of Institution of Biomedical Science. Okay, that's IBMS. Okay. So I have extensive experience when it comes to blood transfusion. I've been opportune, of course, to work in Nigeria and, of course, work here. And currently, I'm a lecturer in one of the UK universities. So we are going to look into the blood transfusion services then the idea is to try to see how we can explore the challenges and advances of this aspect of pathology laboratory. Because I believe that at this point, we all know that pathology laboratory is a big word. Biomedical science, or like you call it in Nigeria, medical laboratory science, or scientists, in pathology lab is a big word. So this is just one arm of that pathology laboratory. So we're going to look at a lot of things. So the outline of what we are going to be looking at, and please, before I continue, can I say feel free to ask questions where possible, and I'm happy to answer the question. If I don't know it, I'll tell you guys I don't know it, but don't worry. So the outline, we're going to look at, first of all, what exactly is blood transfusion services. Then from there, we're going to look at blood and its products. And then we can talk about the challenges in blood transfusion and look at the advancement in blood transfusion services. And of course, look at the blood standard. Because at the end, why I put this one at the end is because if there is no standard in the laboratory when it comes to blood transfusion or blood transfusion services, that can impose more challenge in addition to the challenges that is already facing, okay? So that's why there's a need to ensure there's a standard. So I hope that by the end of this session or this presentation, you should be able to explain blood transfusion services, explain challenges in blood transfusion, advancement in blood transfusion. And now let's look at the background. So when we talk about blood transfusion, so I might be asking some questions as we progress. Please, you don't have to if you think you don't want to answer, but if you could pop in your answers or maybe indicate, and I'm sure they'll give you access to give me the answer, that would really be great. That will help me to actually know, what that I may need to add to my presentation. So when we talk about blood transfusion, is also big. There's a lot of things that goes on in blood bank. And like the name sound, blood. So blood, as it may be, we already know there's what we call a whole blood. Okay? So if we say blood transfusion, what we're then looking at is what exactly are we transfusing? I know that when I was in Nigeria, we transfuse whole blood. That is not what we do here in the United Kingdom. So we transfuse blood based on the component of that blood, okay, which we are going to look at in detail. And of course, in transfusing that, it then means that there are a lot of conditions or some certain kind of condition that can require us to be able to transfuse some certain kind of blood product. And it might also interest you to know that we've been able to, of course, like when we talk about something like anti-D, I think you guys call it Rogan in Nigeria, okay? So when we talk about something like that, these are commercially prepared medicine. So, there's been a technology that mimic what that happened naturally to be able to protect someone in a case of maybe blood transfusion or implantation, okay? Now, blood transfusion generally talks about introducing antigens or maybe introducing antibodies, as the case may be, in any form into a system of someone that requires it, okay? Now, I will explain that more. Then, that leads to what I was trying to say about blood products. So we have is blood products. So in blood transfusion I'm going to be presenting today, I want you to look beyond transfusing a whole blood. When you transfuse a whole blood, you are transfusing a lot of things at the same time. So, but here we transfuse based on product, okay? So we're going to look at that product and why we need to transfuse that. Now, because of the possibility of errors, which is one of the challenges associated with blood transfusion or blood bank, so we are also going to be looking at automation. So, and that is the way of trying to minimize the possible errors that can occur due to manual testing, as the case may be. Even though this might look like is a positive thing, it also has its own challenges, because then there can be a lot of things that can interfere to that. It doesn't take our job away, but it gives us a platform or opportunity to be able to monitor the automation, the analyzer, to see that whatever thing that is happening, whatever thing that is being produced is as required, is according to the standard, okay? So we are going to look at how to use that automation, even manual testing as well, to look at some testing in blood bank, okay? Of course, you guys already know in blood bank, the basic thing is blood group, okay? But there are some testing I'm going to be mentioning that, hopefully will benefit you. Now, here in the United Kingdom, because of the possibility of the danger of this aspect of pathology laboratory, there has to be a lot of guidelines, which I believe we also have in Nigeria. But what happened here in the UK that we are very strict with this guideline. As a matter of fact, these guidelines, when, to make sure that people follows it, there's always an annual report. And following the outcome of the annual report, it then helps the regulatory bodies to work out, are we making progress or is there anything that may need changing? So this is how new policies, many of them I'm going to mention today, comes up. Now, one of those guidelines are the ones that, is being given by what we call MHRA. Basically, it means Medicine Health Care Regulatory Agency in the United Kingdom, okay? So they regulate for blood and yeast product and, of course, medicinal product as well. Now, there's also what we call UCAS. UCAS is like when you talk about, how do you guys call it again? I think Medical Laboratory Science Council of Nigeria, something like that, okay? So now this is UCAS, which is United Kingdom Accreditation Services, okay? So that is what it stands for. Now, what it means that this regulatory body, when you talk about UCAS, they look at all the whole pathology laboratory, okay? To make sure that whatever activity that is going there reflects ISO laboratory, okay? Now, and these are just, so they make policies to make sure that the standard are maintained. Now, I think this heading now talks about blood transfusion laboratory services. Now, this is where I'm going to try to talk to us what that really happened here. So one of the things that we know in the pathology laboratory, first of all, can I just say something? I know we do it in Nigeria, but I can't remember how much that is well separated. So here we have, of course, specimen reception. Okay, someone who works as a specimen reception does not necessarily have to be a biomedical scientist, but biomedical scientists can assist them, can help them. So I say that because you will notice that in specimen reception, they are the one that receive the specimen. But when it comes to blood transfusion here, we want to receive our sample ourselves. So we have a different kind of policy when it comes to sample acceptance. So we call it maybe the criteria of accepting the sample. So I'm going to give us example, just explain this and make sure I don't come back to it. Is the fact that here in the UK, we have what we call 5 identifiers or maybe 3 identifiers. So for something like hematology or microbiology or other department, you could have maybe 2-3 identifiers might be okay. For example, my name is Emmanuel Obodo. If you could get my name correctly and get maybe my hospital number or what we call NHS number correctly, maybe my date of birth correctly, that sample is likely to be accepted. But when it comes to blood bank, in fact, let me also say this, because my name is Emmanuel, Emmanuel could be spelled starting with I, but my own started with E. So let's say somebody thought I know what Emmanuel is and start with I. In blood bank, we're going to reject it. So in blood bank, we are not just after talking about the names of the patient. We want to make sure that it is correctly, spelled out. For example, things like Stephen can be spelled as S-T-E-V-E-N. You could also spell Stephen as S-T-E-P-H-E-N. They are all, whichever way it goes, you are correct. But when we look at the system, which is by the way we call laboratory information management system. So when we look at that LIMS, what happened that if the LIMS spelled it as S-T-E-V-E-N and what you are writing on the container is P-H-E-N, we are going to reject it. So that's why in blood bank, we want to accept our sample ourselves, because in other departments, they could say, okay, it's Stephen anyway. Maybe it's just an error. But for us in blood bank, we don't want to make that mistake. So we accept our samples ourselves, okay? And in accepting it, one of the ways we do it here is that we don't assume that we know the name of the patient. we try to be spelling it maybe E, you look at the system M, you look at, so you go that way until everything is correct before you can be able to now accept it. Now, then we have what to call testing. So I know that when I was in Nigeria, one of the things we do is mainly do what we call type block grouping. Okay, type block grouping. We don't necessarily do type block grouping here. What we do is what we call card grouping. And in doing that card grouping, can I also mention that while in Nigeria, when we do type grouping, what we are actually doing, in which we do in most cases, is just forward grouping anyway. But here as well, we try to do a reverse group, which I think some people also do that in Nigeria. But what is a little bit different, which I never had the opportunity, I'm not sure what is going on now, is the antibody screening. So sometimes in blood bank in Nigeria, what we focus mainly is what is a blood group of this person, maybe do a cross match for people who wants to do cross match, then issue that unit. But for us here, we know that even though that the ABO can be compatible, but maybe there can be other IgG antigens that may not be compatible with such recipients, and that need to be investigated. In fact, let me dwell on here a little bit. There is no two blood that is 100% compatible. I know this might be challenging, but that is simple truth. You know, because when you look at two patients or two people that have the same blood group, the ABO, when I mean AB, I mean maybe antigen A, antigen B, or no antigen, whatever, in terms of your blood group A or blood group B. The ABO may appear compatible theoretically, but someone who is blood group A, another person is blood group A, there can be a variation of their IgG antigens. And this is what this antibody testing try to find out. When we talk about IgG, you talk about a number of, because apart from the antigen A, you see on the surface of the red blood cell in terms of blood grouping, okay? Or maybe antigen B, you see on the surface of the red blood cell of blood group B. Now, we said our blood group O has no antigen. That is not actually correct, because there is no blood that doesn't have any antigen. But what happened is that when we talk about ABO grouping, when we specifically talk about ABO, then you can say that blood group O does not have antigen A or antigen B. As a matter of fact, someone who is blood group O positive has antigen. The person has got D antigen. I know we call it resource antigen. So that means there is antigen. Now, but why I mentioned that a D antigen is IgG antigen. But when you talk about AB, like antigen A or antigen B, they are called IgM antigens. Of course, you can also, when it is antibody A or antibody B, it's also called IgM antibodies, okay? Now, if that is the case, when we say someone is blood group O positive, I'm using that blood group O positive because we said that blood group O does not have antigen, but what is correct is that it does not have antigen A or antigen B. So that is what is called, because it does have other antigens, which the obvious one is the D antigen. For some of you that wants to come for, that is applying for a job to come to UK, if you really want to mention avoid using the word resource, just tell them D antigen, because, you know, it brings this home to us that D we are talking about is an antigen that can be found on the surface of that red blood cell. And because of that, we can say that person has that, okay? Now, if that is the case, then there are other antigens, which are also IgG antigens. So D antigen is IgG antigen. That's why you can have maybe antigen K, antigen E, antigen, a lot of them, Duffy A, and all of that, which I'm going to show you as we move on. I'm only trying to say that to make sure for effective blood transfusion, where it should be safe, we shouldn't just focus only on the forward and reverse grouping. There's also need to determine the possibility of someone having any of these IgG antibodies, okay? Now, let me summarize it this way. If I am blood group O, and being blood group O, I don't have antigen A, I don't have antigen B, but I might have antigen big E, okay? Maybe I don't have antigen K. So what it means that if you blindly give me blood that is the same blood group O, but that blood has antigen K, but I don't have antigen K, but both of us are blood group O, what is going to happen then? because I don't have that K antigen, which is IgG antigen, by the way. So that IgG antigen will sensitize my system. And that can be maybe in a case of, there are different types of transfusion reaction. So this can lead to maybe what we call delayed transfusion reaction, okay? But anyway, there can be sensitization. And what it means that because the K antigen, I don't have it, my body would then produce K antibodies. So when we do this antibody testing, if it is positive, it kind of show that this person has developed antibody of antigen that he or she does not have. And of course, if he or she has it, that means it is now auto antibody. I thought I should just mention that. Now, there's also what we call weak D and partial D, which I'm not sure what is going on, like I said, in Nigeria, but I don't remember us determining this. So what we know is positive, we can't even differentiate, we don't differentiate it, let me not say can't. Okay, but there's a need to find out whether, someone's reaction you are seeing, is it that is a weak D? When you say blood group A, red source, or D, antigen positive. So sometimes that D antigen may not necessarily be a full-blown D antigen. It could be a partial D. It's not a full, in fact, it's not a D antigen. Because there's a difference. The weak antigen, weak D antigen means it's a D antigen, but it is weakly expressed. That means the person has got the D antigen. But what happens with the partial D antigen you might see is that there is the whole proteins that make up the D antigen is not complete. Let me use that one. And because it's not complete, you cannot really say that the person is D antigen. Now, let me tell you why it's important to differentiate these two. It's important to differentiate these two when you are dealing with women within childbearing age. Because if you see partial D and you say this person is D antigen positive and you give the person blood that is D antigen positive, this person might end up developing antibody D. And of course, you all know it might cause problem in future pregnancy. So that's why we have to differentiate the two, okay? Now, in doing that, because I'd already mentioned the IgG antigens, then we now need to have to find a way to identify these antibodies. So if someone has developed other antibodies that is not, like antigen A, antigen B, antibody A, antibody B. There are other antibodies someone can develop. Maybe anti-K, like I've mentioned, anti-E, anti-Dufi A, anti-MNS, like anti-M, anti-N, anti-S. There are so many of them. So if someone developed that, it is important that we find out. And when we find out, then we can then be able to find a better option of blood we can give to that person. Now, I say this because there are guidelines surrounding this whole thing. Okay, when I come to that point, I'm going to mention it more. But there are guidelines surrounding this. That's why in the UK, there's what we call electronic issue. Like you say, your electronic, now issuing blood, okay? So electronic issue is what we call like computer cross-match, which is ideally, actually, I would say, what is common in Nigeria, because sometimes we say, okay, this person is blood group O, we carry blood group O and give that person. We do the same thing here, but in a way that the guideline regulates it to make sure that the possible mistake is well minimized. So what we do is that once we have ascertained that this is a blood group of this person, we can actually give blood without necessarily doing serological cross-match. So we call it computer cross-match, and that is what we call electronic issue. It is in that blind transfusion that someone can possibly develop these antibodies I'm talking about. Like I've mentioned about myself, I don't have antibody K, sorry, I don't have antigen K, but I'm blood group O, and you give me blood group O that has antigen K in that blind transfusion. What would then going to happen? I will develop antibody K. And next time when I come, then you will see that I've developed antibody K. Now, let me tell you why UK has done this to minimize the problem of this. They've done this because even if you develop it, we now have the possibility of dictating that. We're not going to allow that to continue. Why? Because we have a guideline that's talk about sample validity. I don't think I have it here. But sample validity, mention things like, is a guideline that states that if someone has not been transfused within the last 90 days or 3 months, If someone has not been transfused within the last 90 days or 3 months, the person blood group will be valid for 7 days. But if someone has been transfused within the last 90 days, or even if the person is pregnant, because pregnancy is a form of transfusion, because there is implantation, meaning there is antigen that is in someone, that is a form of transfusion. Okay, so if somebody has been transfused within 90 days, or the person is pregnant, the person's blood group will only be valid for 72 hours. The reason for this is that evidence has shown that these IgG antibodies can develop, okay, within 72 hours. So this is what we do. What it then means that the sample validity I'm talking about here, let me also go a little bit further to mention. We have what we call current group, and we also have what we call historic group. Here we try to continue testing the blood group to make sure that wherever there's any change, we can be able to find out. So we have a current group, we have a historic group. Let me explain what I mean. So we don't just test someone once and say, this is the blood group of this person. We don't just do that. So we test you the first time, we then have to test you another time. Once your previous sample and the current sample say the same thing, that this is the blood group of this person, then we can say that is the blood group of this person. If it is someone that is rushed quickly to the hospital, and this person, this is the first time, and they want to take the sample, because we need 2 samples to test, and we don't want the mistake to happen. Now, the guideline that we use here to make sure that that will be the result of that patient is that 2 different staff will have to collect the sample, and also it has to be done at least 10 minutes apart. What it means is that if you're a doctor or you're a nurse, so you can collect this patient sample who has been rushed to the hospital, sent to the blood bank. After 10 minutes, another person will come and collect from the same patient, send it to the lab. Now, when these 2 samples will analyze it and will get the same result, we can now say that is a blood group of that very person. What it means that the first one you did will now become, the 2 samples, the first one they sent will then become historic. The second one they sent will then become current. Now, let me tell you why I mentioned that. We don't issue any blood to anyone as a product is not emergency anyway, but outside emergency, we don't issue any blood without the person having both historic and a current group. So this is how we monitor that. So when I say that the sample is valid for 7 days or 72 hours, as the case may be, what I'm actually saying is that if someone has been transfused, after 3 days, after 72 hours, we need another sample. If someone has not been transfused, after 7 days, we need another sample. If it is a pregnant woman, after 72 hours, we also need another sample. What it means that blood group and antibody screening is one of the routine things that we do here. We have to continue testing that, okay? I feel like asking a question right now. Let me see if you could tell me the answer quickly. That would be great. What do you think that can change blood group? Or maybe can blood group be changed? If the answer is yes, what do you think can change blood group? If you can pop it on a chart or indicate, hopefully, yeah. Please, can you, yeah. Okay, is it Joy? I think Joy is raising hand. So yeah, let her say what she think. Yeah, go on. Thank you, Joy.
Can I go on? One of the things that can change blood group could be medications. Medication, okay. The drugs the person could be taking could make the. I disagree with you. Yes, that's one of the things that can change it.
Okay, that's fine. Go on.
Sometimes too, when the anti-serals are not stored properly in the right temperature, it could make the anti-D not to react.
That's an error now. Close to it.
So that one is just technical error. So is the blood group has changed. Okay. Right. We're talking about when there is standard. So yeah, medication, as I agree. Any other suggestion? Okay, that's fine. That's good. Thank you so much, Joy. So actually, yeah, medication can do that. In fact, one other thing that medication can actually do is that I know you guys don't use automation mainly, but here, depending on the kind of medication that the person is on, you might realize that you can't even get any result. you can't be able to say that this person is blood group A or B. You can't. You are going to get what we call discrepancy, okay, meaning nothing is really agreeing with the blood group. Remember that here, like I've told you guys, when we're doing testing, we do, let me pick this. So when we're doing, just 1 minute, let me pick this up. So when we're doing this routine thing, so this is a routine test. So we do the ABO blood group. In this ABO blood grouping, we do both forward and reverse group. So we want both the forward and reverse group to agree. If they don't agree, it's a discrepancy. So we need to investigate it. And of course, we also do antibody testing. So yeah, medication can cause that. Now, and you can now see that if we now do a current group from what I've told you, if it looks like you are getting a different result, what do? You investigate. It is through that investigation you can now find out, oh, maybe it's a medication. Are you following? Then it can now make you to now find a better way to do that. Most times when medication affects it might require a technique such as maybe elution techniques to be able to remove that interference, and that way, the result can then come out the way it's supposed to be. But that's by the way. So medication actually can have effect on the blood group. I want you to note what I've said. I said it will have effect. It may not necessarily change the blood group of that person. Okay? Now, but one of the reasons why I asked that question is because there is other things, one main thing that is very likely to totally, absolutely altered the blood group of someone. And that is, if you know that the blood is produced in the bone marrow, you will then know that bone marrow transplant can do that. Do you understand? So if someone has undergone bone marrow transplant, the blood group can change. Now, one of the reasons why I mentioned this was because if you do the current group, so maybe after 3 years or 10 years, because what the system will use, will always going to maintain the historic group. Once you've done it at least twice, even if at once, even if you've done the blood group once, the system will always going to have a historic group. But to issue blood, you then need a current group. Now, what happens is if someone comes in and the current group seems like it is different from what we used to know, you can investigate. Then from there, you can find out, oh, this person has undergone bone marrow transplant. Then that can explain that. I hope that makes sense, okay? So I thought I should bring that up. The reason why I'm saying this is because when we talk about antibody identification, we are looking at other things, not just your ABO blood grouping. And this is where issuing blood comes in. So I've mentioned we issue blood either electronically or by cross-match. So once we notice that this person have developed an antibody, we'll then do what we call serological cross-match. So if you are being asked a question, in issuing blood, it's either by computer cross-match or by serological cross-match, okay? So computer cross-match, you don't necessarily do a physical cross-match. The only criteria is have a current group, no antibody, present, then you can just issue the blood. But serological cross-match means there is antibody you've detected, then you cannot be able to, do the cross-match, and if it is compatible, you can issue it. And this is where phenotyping comes in. So if we have other antigens that can be found on the surface of the red blood cell, what it then means that in order to see the antigens that may be different from these two patients that is the same blood group, we then do phenotype. So when we say phenotype, phenotyping talks about, detecting or determining the IgG antigens that are possibly present on the surface of red blood cell of a patient. So that's what phenotyping does. And then there's also what we call Klahawas, okay? In this Klahawas, it's kind of trying to measure, the presence of maybe photo cells in a mom, when you are suspecting a kind of internal bleeding, or as the case may be. Of course, when you talk about your, when you talk about your fetus maternal hemorrhage, okay, where maybe a woman is D antigen negative and the baby is D antigen positive, which can cause a sensitization, then we can now do the Klahawas. I think with this, I've given us the overview of what goes on in blood bank transfusion. Now, of course, we receive the blood, we also store the blood, and hopefully the storage temperature of the red blood cell. So what I want us to know here, please, before we move on, is that we have different components, and I'll come to that. So each of these components, they can be stored differently, and when I get to that point, we can deliberate on it more. Okay, so still on that, we have what we call neonatal transfusion. So there's we have a different guideline for transfusing a baby or neonatal patient compared with that of the adult. And of course, we have what we call issuing emergency blood product. So in the case of emergency, we have a protocol. Remember what I said. If it's not emergency, for us to issue blood, we need a current group. And from what I've said, if we need a current group, that means there has to be a historic group, okay? Now, but in a case of emergency, if there is no current group, if there is no historic group, we cannot say we cannot issue blood because it's an emergency. So what we do, we now activate a protocol, which if I go into it now, except if it come off like a question, then I'm happy to deal with that more. But there's a protocol on how to go about this as well. Now we have medicinal product, and that's why you look at anti-D, Otaplex, and so on, okay? Then we look at automation, which is what we used for testing. And of course, if we're going to do all of this and maintain standard, there's a need to ensure that there's an effective training, because if there's no effective training, it can have effect. And that effective training can then lead to what we call competence. So somebody needs to be competent to be able to work in blood bank. I think I've given you overview. Now, just to, does anyone have any question before I continue? Because I want to play a video now, so I just want to see if you have any question. Just a brief question, something before I continue. Any question? No? Okay. Yeah, good. All right. If there is no question, can I just play this video? So this video hopefully will show you, I try to get a short, second video just to make sure you see, how the blood group and antibodies, mainly blood group, is done here. So this card you are seeing is the card group I mean. So if you remember your anti-sera you use in Nigeria, you can see the color here at the center. Anyway, let me talk. Right. That's very good. Can anyone, if you are comfortable and you want to tell me what you thought this video is trying to communicate, can you indicate and just tell me? But there are a few things that I really want to highlight. Yeah. Okay, nobody. That's fine. If there's nobody, can I just mention that if you look at that, you're going to see there's a card. So how this automation work? Of course, there's going to be reagent inside the analyzer first. So what should be in that reagent? Now, remember that when you are doing your blood group, you are using anti-sera like it's being used in Nigeria. So you use anti-sera and then test the patient blood group. But now you have a card that is already, this anti-sera is already embedded in this card. Okay, whether it is anti-sera A, anti-sera B, D. Of course, there's also a negative control where there shouldn't be anything to show us whether the result is valid or not. Now, the way the card is, I don't know how you can picture this. So you have anti-sera A embedded, anti-sera B embedded, then you have anti-D embedded. The fourth column will be just negative, is a gel, but there's nothing there. So that should come up negative. Now, there's also another side of the card, which will now have A, and another one will have B. That A is talking about the antigen A, and B talks about antigen B. Now, let me tell you how it works. So we use commercially prepared A cells and commercially prepared B cells, and this will be inside the analyzer. So we have commercially prepared A cell, commercially prepared B cells. Now, we now load the gel card, which now have the anti-sera, okay? Then what we're going to do, we now put the patient sample. So this patient sample, before we put it, we'll spin it down, we'll centrifuge it so that there can be a separation between the red cells and the plasma. What the analyzer is going to do is this. The analyzer will then pick the card. I'm sure you guys saw when he picked the card. When he picked the card, it will puncture the cards. So what it's going to do is going to do a dilution. So it's going to miss, it will go, the probe will go inside and pick red cells and kind of dilute it. Okay, let's say, let me make it easier for you guys, like normal saline, but we'll call it diluent. Okay, so it can dilute with a diluent, and once it dilutes it, then it will carry the red cells and put in antisera A, which is embedded in a gel, and B, and D, and of course the control. Does that make sense? Now, once it has done that, that will test for forward grouping. That is what we do in Nigeria when we do the tie grouping. Now, this reverse grouping, which we can also do by tie grouping as well, what is now going to happen is to now, because this testing of forward grouping use the patient red cell, we're now going to do another one that will use the patient plasma, like you also do it on the tie in Nigeria. So, but we now use a known A cell, a known B cell, no longer the patient cell. So the analyzer will pipette that A cell and put on the A well, and pipette B cell and put on the B well, then pipette the patient plasma and add on both of them. So that is how it works. It then incubates it. If you look at that, there was a centrifuge. Then after the incubation, it will centrifuge it. Now from the centrifugation, once that is done, it will pick it and read it, okay? So once you read it through the scanning of the barcode and scanning, the result, what it can, based on what is transparent or what is not transparent. So once it read it, it can now be able to tabulate what that result is. If you work towards the end, which is actually what I really want to mention, towards the end of that video, you are going to see there was a connection. I don't know if you saw that wire, or maybe that kind of networking between the system, the computer, which is laboratory information management system, and the analyzer itself. So that is called an interface, okay? So this interface means that the analyzer has processed it. Once it processes it, okay, then of course, if a biomedical scientist look at it and you're happy with it, once you accept the result, that interface between the analyzer and the LIMS will now transfer that result to the analyzer. So, sorry, to the LIMS. So when you now go to your computer and check it, you can now see that result. So that's what happens. So with that, it can do both the forward and reverse grouping, and two of them has to agree, okay? So now, another side of the test, which is IgG antibody screening, which I didn't have the video here, but let me explain it to you. The same principle, but instead of using ABO gel card, is going to use what we call IgG card, because we are measuring IgG antibodies, okay? Now, what we are going to use is a known commercially prepared, cells. So we can have cell 1, cell 2, cell 3, as the case may be. So these non-commercially prepared cells will now contain different antigens. I will show you some examples. Now, let me give you this. Now, let's say cell 1 might have antigen D, antigen K, antigen E, antigen Duffy A, and cell 2 will have different antigens, meaning there is different antigens on each of these very cells. What this analyzer is going to do is, again, puncture the IgG card. Pick, if it is an analyzer that uses cell 1 and cell 2, it will puncture it in two places. Cell 1 will go on the first place, the cell 2 will go on the second place. Now, remember, these cells has different antigens. Then it will now use the patient plasma and put on each of them. Again, incubate it, then centrifuge it and check. If it is positive, it means that the person has got antibody of any of the antigens that is on those cells, on any of the cells, either both or either. So once you find that out, you don't know whether it is, because if there are more than one cell, one antigen is there, it means that result you are seeing, you don't know the particular antibody that patient is reacting to the antigen with. For example, if you have antigen K, antigen E, antigen Duffy A, and it is positive, so the person may be having anti-Duffy A or anti-K or anti-E. You don't know the one. So what you are now going to do is to do what we call antigram or antibody panel. That will then help you to identify the antibody. Hopefully that makes sense. All right. Now, sorry, I was going to answer something. I think I've already said it already. Can someone tell me the blood product? If you have confidence to tell me the blood product and what, why we should transfuse them, that would be great. You can put it on a chart, or you can add the, you can indicate. And if you can actually indicate, I will appreciate that more. But if not, you can put it on a chart. What are the blood products, and when do we give it? Because I've told you guys that we should not really transfuse a whole blood. No, that is not really good practice. We should be transfusing blood components. So what are the components of blood, and when do we supposed to issue such unit, or at which condition is any of the units required?
I think that information on the chat, someone said fresh frozen plasma.
Yeah.
And another person said platelet-rich plasma, red cells.
Yeah.
Somebody said cryoprecipitate.
Correct. Okay, that's fine. I've gotten more than enough of what I want. So these are the products. So that is actually correct. All of them are correct. So if we look at the blood component, all you need to think in terms of your normal centrifuge. If you centrifuge blood, what do you see? You see red cells. You see the buffy coat. Now, the buffy coat, you can get maybe the white cells underneath a little, and the platelet a little bit up. Then you cannot get the plasma. Okay. Now, these are the components. Okay. Now, but there's something I want to ask. Since you have mentioned FFP and cryo, is there any difference between FFP and cryo? Because both of them are plasma. You can also pop it on a chart. Because two of them, they are plasma. So is there any difference? Yeah? Okay. That's fine. I'm going to explain that. But if you already know why we give red cells, okay, in a case of generally or whatever condition that causes suspected anemia, so we do that. So platelet, of course, if there's thrombocytopenia, then we do that. Any condition that may lead to that. Now, where it can be a little bit challenging is these two, FFP and cryo. Okay, so now let's take it one after the other. So red cells I've mentioned, you know when to give it. Then plasma, this plasma is generic. So this plasma can be fresh frozen plasma, or it can be cryoprecipitated. Okay. Now, when we say fresh frozen plasma is a plasma, when we say cryoprecipitated is a plasma, but the difference is what they contain. Now, let me say this. Remember that most of the proteins, I think one of the common questions, even when I was in Imo State, I think one of the common questions is the difference between serum and plasma. I think Nigeria like to ask that question a lot. So we used to say that the plasma is maybe should I say liquid part of the blood, maybe in the presence of anticoagulant, which is correct. Okay, the other one, absence of anticoagulant, which is also correct. But the way I would like you to look at it is this, in a maybe more refined scientific way. Or is that, think about a sample you collect on a plain tube and a sample you collect on any anticoagulated bottles. What do you think will happen? If you mix them properly, it doesn't matter what happened, the one of the plain tube is going to clot. But the one on that contains anticoagulant is not going to clot. What it means is that if you centrifuge the one of the plain tube down, you are still going to get a liquid part of the blood. But on this occasion, it's not serum. When you centrifuge the other one, you're also going to get a liquid part of the blood, but it's not called plasma. Now, the difference now is the fact that this one we call serum. A lot of protein has been used up. Because if you say that it has clotted, that clot means that a lot of clotting factors have been activated. So many proteins have been used up to be able to clot the sample. And that is why you are likely to find more proteins in plasma than you would find in serum. Okay? Now, I mentioned this because of what I want to explain. In plasma, it contains clotting factors. That's why I mentioned that. Okay, so what it means that when we suspect in a case of where coagulopathies, where there's abnormal clotting, factor, maybe factor deficiency, or as the case may be, once you suspect there's a clotting issues here, okay, the person might be deficient of any of the clotting factors, you can give plasma, FFP, to enrich, to augment whatever thing that is going on there. And that is also why when somebody is, in a case of major hemorrhage, somebody is bleeding, the person's system is, the clotting factors can be used up as well. And then the plasma can also be given to replenish that a bit. And of course, to balance the hemostasis of the percentage of the red cells and the plasma. So the plasma itself is rich with clotting factors. That's all I'm trying to say there. Now, but the cryoprecipitated is also a plasma. But now this one is rich in fibrinogen. Remember, fibrinogen is still a clotting factor. Don't forget that, okay? Now, but it is concentrated in cryoprecipitate. You have high fibrinogen. So once we notice that someone is having low fibrinogen, we can give the person cryoprecipitate. I think that is it. Then we'll have white cells and have platelets. And then, of course, I mentioned things like clotting factors, like I'm trying to explain. Now, in these clotting factors as well, let me dwell here a little bit, just explain something. It's not just because someone is bleeding. Sorry, before I continue, Obina, how many minutes do I still have? Because it seems like I still have a lot to say. Let me not be carrying on, be talking and forget. I still have many slides to go through. How many minutes do I have?
Okay, I think you have like 50 more minutes.
Okay, that's fine. Okay, I should have time to do that. Okay, let me continue. So now, one of the reasons why I mentioned the clotting factors here is very, very vital. It's vital because when you talk about the cryoprecipitate or plasma, like I've mentioned, if somebody is bleeding, I've explained that, or factor deficiency, I've explained that. But when we say coagulopathies, let me ask that question. What exactly are we talking about? If someone can pop it on a chart or just tell me over. I just want to make sure before I carry on saying what I want to say. What's the meaning of coagulopathies? Any answer? Okay, yeah, Marianne, thank you. Go on. Obina, can you allow her to talk, please? I think Mariam, Jamila, something like that. Can you unmute her, please? Obina, are you there?
Yes,
Okay, that's fine. All right, thank you. Yeah, you can go on, Marianne. Go on. I think you've been unmuted.
Okay, it's usually as a result of maybe an excessive bleeding or clotting going on in the body.
So say that again. There's something that I think you said something right, but I didn't quite get it.
Usually occurs when there is an excessive bleeding
or you
in the body, or clotting in the body.
Okay, that's fine. All right.
Yes, sir.
All right. Thank you. So when we say from the word coagulation, so we are looking at clotting cascade pathways, which can be either intrinsic, extrinsic, or common pathways. Okay. Now, what it means then, I may not have, this session will not allow me to explain all of this. I'm just going to tell you guys overview. So what it then means is that there's a possibility that someone could have, like what Mary I'm trying to say, someone could have a factor deficiency. Remember that each of these factors are required to be able to maintain effective or ensure effective hemostasis, if I'm to use that word, okay? Effective activation of the clotting cascade, okay? Now, what it means that if one of the factors is deficient, what is then going to happen? The person is likely to bleed. For example, when we say something like hemophilia, the person has a tendency to bleed. Why? Because the person can be deficiency with either factor 8 or factor 9. Okay? So when we say hemophilia A, the person has deficiency of factor 8, hemophilia B, factor 9 deficiency. So that could make the person to bleed. Now, but that is one way. One of the reasons why I asked this question was because of the people that has a tendency to form a clot. Their system has a tendency to form a clot. So, the clotting cascade is supposed to be activated in a case of abnormality where there's a bleeding, as the case may be. Something needs to cause the activation of the clotting cascade. But if for any reason clotting cascade suddenly just be activated and the person starts forming clot, that can be a problem. I would have loved to ask questions, but because of our time, I'm going to explain it. So the problem of that internal clot means the passage of the blood vessels could be blocked. And of course, that could lead to stroke, paralysis, or anything like that, okay? And this is actually somehow what, let me explain it, D-dimer measures. So when you say D-dimer is not necessarily, somehow, depending on how you look at it, D-dimer is not necessarily measuring clotting cascade, if I'm to use that word, okay? What D-dimer is measuring is we call it FDP, that's fibrin degraded product. So for clot to form means that fibrinogen has to be converted to fibrin for clot to form. So now what it means that when clot is formed, that means there's a fibrin formation. So when that fibrin, start degrading and start floating in the system, which is now FDP, fibrin degraded product, that is actually what D-dimer measures. And this is why D-dimer can be high in the case of someone who have deep vein thrombosis or pulmonary embolism, or something like, let me use a common one, like something like rheumatoid arthritis. Now, because of the condition of this, or what you call as well DIC, okay, intravascular.
Disseminated intravascular.
Yeah, so once you have that, that could also, that condition make the person system to kind of form clot. There's also what we call TTP, okay? So this TTP also means that the blood vessel, there can be clot forming in the blood vessel. So these are different coagulopathies. I'm trying to explain something here. So because of this possibility of this person forming clot, what's the danger? Stroke, paralysis, death, as the case may be, cardiac, malfunction, and all of that. Because of that, the doctors are going to prescribe anticoagulants. That's actually why I explain all of this, okay? So the doctor would then prescribe anticoagulant so that the person can now have anticoagulant either orally or intravascular, depending on what the person wants to target. So this anticoagulant can then help to prevent this abnormal clotting. You see it now. But why that is solving a problem is creating another problem. Because if you put if someone is taking anticoagulant, there's a possibility that if it is not effectively monitored, the person's system might be watery and the person might bleed to death, depending on, So sometimes you guys will go for interview and they say a patient is bleeding from the nose, rush into the air, and bleeding from the nose, from the mouth. These are what they are expecting from you, okay? So the doctor would then prescribe this oral anticoagulant or intravascular anticoagulant, and that would then be monitored, okay? So, and that is where this clotting factor thing I'm trying to explain comes in. So because with this, once that is now prescribed, what it means is that it's going to attack the clotting factors, preventing it from happening. Okay, so one that is attacked. By the way, let me also say this in passing. Remember that your body has a natural anticoagulant, but I don't think I have time to explain. But your body has a natural anticoagulant. So if someone starts bleeding, okay, the body will start to activate clotting cascade. Once that condition is controlled, the body will then start releasing its natural anticoagulant. Okay, like when we say something like antithrombin 3, these are natural anticoagulant. Protein C, protein S, these are natural anticoagulant. Now, but in a coagulopathy, this natural anticoagulant can come up, in a manner that they shouldn't come up. And of course, it will make the person's system as well to be watered. But anyway, I'm trying to say that this oral anticoagulant or intravascular anticoagulant is prescribed to now be able to inhibit the clotting cascade. So sometimes what they do is to attack a particular site of the casket, or maybe attack what they depend on. For example, things like vitamin K, like things like warfarin will attack that vitamin K, and that is required for extrinsic pathway to be effective. Now, another aspect of the blood product, which is commercially prepared as well, like I've mentioned this, is what we call anti-D prophylaxis. So for some of you who are coming for interview in the UK, please don't say Rogan, just say anti-D prophylaxis. If that is the answer, whatever thing you have been asked, this is what we want to hear. And this is where we give a woman who is pregnant, who is antigen D negative, give this, then the body kind of mimic as though is D antigen positive, but it's not, okay? Now, that another medicinal product is what we call prothrombin complex concentration. We call it Otaplex. So this Otaplex is now what can be used if we think, this anticoagulant we've given to this patient is now going to cause a problem. If somebody is on anticoagulant, you can't take the person to surgery. You can't do that because the person is going to bleed. So because of that, the doctor, in order to reverse that anticoagulant, can then prescribe for prothrombin complex. I think that's just a few things I want to say that.
This high-volume, high-quality blood testing machine is unique to the blood banking world. Fully automated, it helps ensure the safety of the blood supply by testing donor samples for things like hepatitis B, C, and HIV. In 8 hours, it runs 5 different blood tests on 1,000 donations without human intervention. Between each of these tests, it sterilizes every single probe in a wash solution. Another machine determines the blood type, of which there are 8. They scan the donor's collection bag and document what products they will produce from the blood. Then they weigh it. Overnight, gravity causes the blood to separate into its 3 components. So a worker remixes it, preparing it for machine separation. She then packs the blood in the bags for the other components into what's called a liner. She makes sure the liners are balanced and will put a rubber weight inside when she needs to. Balancing the liners keeps the centrifuge machine spinning properly at 4,000 RPM as it separates the blood into layers. She then hooks up the unit of separated blood to an automated extractor and once again matches the unit with the donor. The extractor fills a bag with just red blood cells. As the machine fills the bag, it leaves behind a mixture of blood and platelets in the original container. As it extracts these red blood cells and leaves behind a portion of blood and platelets, it also fills another container with pure plasma. An incubator keeps the processed platelets well mixed. They only have 5 days to use these platelets. However, they freeze plasma and can use it for 12 months. Finally, they filter out the white blood cells from the red blood cells using what's called a leukoreduction filter.
Right. Because of our time, I may not ask questions, but what that analyzer was trying to show was the separation technique. So when someone donates blood, here is a whole blood. So we now have a techniques where we can be able to separate that blood into different components. That is what is trying to show you there. Okay. If you have any question, you can ask me later. Now, there are different blood bank services, donor centers, transportation. So someone needs to transport that. And of course, the testing, manufacturing. So the manufacturing talks about manufacturing, whether it is red cells or FFP or cryo, as the case may be. And of course, there's a department that look at the quality control monitoring, and then of course, bacteria screening as well. And hospital services are the ones that are that kind of, if the hospitals need any blood product, they want to request for blood or something like that, to be sent to them, they would then phone the hospital services to be able to do that for them. Now, there's also a reference, laboratory. So in most cases here in the UK, there are some tests that local hospital may not be able to do in blood bank. Then we can now refer it to the reference laboratory to be able to do that. But I don't think that should really be a problem. Now, let's look at the challenges associated with this whole thing. One of the reasons why I lay all these backgrounds to see how complex this can be. And the problem with blood bank is that once there's any little mistake, that can affect the overall thing. It can affect, it. So, for example, there's a problem with the blood demand and discrepancy. So people continue to demand blood, and sometimes here we run shortage of, stock, or maybe you want a certain kind of blood product and they say they don't have it, and then we try to improvise, another method, or as the case may be. Now, a discrepancy is also the situation whereby the possibility where you can have blood where due to that shortage, you cannot give another blood, even though theoretically that can be compatible. Let me give you an example. Let's say in a situation whereby someone is D antigen negative, but because of shortage of blood, as the case may be, you give D antigen positive. technically it's a discrepancy, but anyway, because that we know that should be okay. That's why we'll give it. That's what that is talking about. Now, of course, the storage of the blood, apart from maybe something like plasma or cryo that can really last for a very long time, the rest have a short, shelf life. And that also is a huge challenge. Now, another challenge is the fact that there's a possibility of blood transmissible infections. So, because when someone donates blood, especially here in the UK, sometimes the person have donated blood and the person have gone back home. The good thing that we have a technology that track everything. Even the person who have donated blood, we know where his blood is up to. If I donate blood now, I will know, okay, my blood is not in this hospital. Okay, it has not undergo separation. It has undergo testing. It has not been. I will even get information of the patient that has the sample that took the blood. Okay, so that is how it is. But what it means, at any point we find out that there's a possibility of infection, so that we can be able to track it. But in most cases, if this is not trapped on time, a patient must have either of the any of this blood product or maybe all of the blood products. So it's still a challenge. Okay. Now, of course, determining the blood typing sometimes can be a challenge, because even though someone needs to be competent, but where there is any slightly mistake, which could be from the analyzer as the case may be, or lack of oversight as the case may be, that could also affect it. Okay. So most of the problem in blood bank has to do with the possibility of issuing an incompatible unit to a patient, or someone developing infection or developing what the person shouldn't have had if not that the person has been transfused. Then another thing is cross-matching, and this, of course, can also be demanding as the case may be. Then you talk about human resources, of course, here in the NHS here, they always short staff as the case may be. So it's still a challenge to us. And that challenge has to do with the suitable infrastructure, which may not really be common here, but yeah, maybe back home could be a common problem, looking at, the structure of the way things should be done. In fact, if you donate blood here, the way you're being treated, it looks like you should be coming every time to donate blood here. Okay, so I think they've got a good structure. Now, resources, constraint, and funding. Now, there's a lot of things, more research that can actually help blood bank. But of course, if the resources are constrained and there's no funding, some of this research may be delayed in trying to improve the services of the blood bank. So these are the challenges that can be associated with a blood bank. And of course, lack of education or effective education and training could also be a problem. Now, one of the reasons why I made a point of those things that I said beginning before this one is that I wanted to make sure that this presentation benefits us more in terms of seeing how far this part of the world has gone, and then we can now start looking at even much more we could do here, okay, and then reflect what we are doing back home. And my idea is that hopefully after this we can be able to adjust our services, where possible, to see that what we're doing is up to standard. So there's automation and technology, which is an advancement, which of course we also have in Nigeria. I'm not sure. Can I ask a question? Is there anyone here that you use automation to do your blood group in Nigeria or wherever you work? Anybody? Okay, Maria, okay, good. Any other person? Right. Does anyone here do antibody panel or antibody screening in your lab? IgG antibody screening, antibody panel. Anybody?
No, we don't.
Okay, that's fine. Okay, that's fine. Good. All right. Anyway, automation and technology is we use it now. Of course, we also have a way of doing a kind of pathogen reduction technologies. Okay, so there's a way, because of the possibility that someone has donated blood, and maybe, what you guys call incubation period. Maybe this infection has not really, or this disease or whatever has not really showed up in the person's system. That can be mistake. But we have a technology, which we can actually use to be able to detect that on time. And of course, that can now help to reduce the possibility of that very pathogen contamination. Okay. Now, this telemedicine and remote blood donation, is where technology can actually be used for any of this blood bank or blood donation. Now, global collaboration, of course, I'm not sure how it works back home, but here there's a number of collaboration between UK, US, and Europe, and all of that, Australia, and all this kind of. So that collaboration makes them what is obtainable here is likely to be obtainable in any of this part of the world. That way, standard can be maintained. Can I even say something here? Remember that when we talk about ISO laboratory, we are looking at international, okay? So if it is international, where possible, each of the countries that are part of the ISO laboratory, they should actually pick up what these other people are doing, of course, because it's a central way of passing information or how something can be done. Then that should then be delivered to each of these countries. The whole idea of ISO laboratory, there shouldn't really be any difference between Nigeria and UK, if that, or any part of the world, if that can be implemented, because it's a central place, and which I believe are Medical Laboratory Science Council of Nigeria. I want to believe they are part of ISO laboratory. I think I'm correct. If I'm not, someone should just let me know. Now, we use in that reduction of the pathogen, we can do what we call nucleic acid testing. This will help us to be able to detect that pathogen on time, even if it is still at the incubation period, as the case may be, before whatever can be able to happen. Now, there's what we call apheresis technology. Now, I'm going to explain this. When I say apheresis, who can tell me what it is? Because this is important that it is explained. Do you know what is apheresis? Let's say apheresis platelet or apheresis plasma, whatever. Do you know what it is? Okay, maybe because of our time, I'm just gonna say, so when somebody donate blood, so I'm O positive. So if you get my platelet A positive, of course, when you centrifuge your blood, your whole blood in a container, red cells are big, plasma is big, but that buffy coat is where you can now start talking about your white cells and platelet. What I'm trying to say that platelet is not that much when you do that separation. So you are likely to have one donor with red cells, one donor with plasma, but it might be difficult to have one donor with platelet. Okay, because of the amount of what you might see there. Therefore, when you get platelets from this patient, O positive platelet here, O positive platelet here, O positive platelet, you put them together. It's called pool platelet. That means it's a platelet that you put together. Now, the technology of making sure that from one donor we'll get as many platelets as we want, the amount of the platelet we want from one donor. That is called then apheresis platelet. So apheresis platelet talk about, that platelet is from one donor, basically. That's what I'm trying to say. So there can be pool platelet or apheresis platelet. Now, radio frequency identification is also another technology where we can be able to monitor what is actually going on in terms of maybe the blood bank, okay? The unit of the blood that someone has been issued, or as the case may be, without necessarily being there physically. With this technology, we can be able to monitor that. And of course, with this technology, we can also be able to intercept wherever we want that to stop, okay? If we detect any problem. Now, let me tell you why this technology is important. Here in the UK, there's what we call recall, and I believe Nigeria should also do the same thing. So recall is that, remember from one blood donation, we can have red cells, we can have FFP, we can have cryo, we can have platelets, where possible, not in all cases, we may have white cells, okay? Now, but let's stick with these four. So with these four, what it means that, at some point, we may find that there's something wrong with the blood product. So we now need to recall it. By the time we want to recall it, we may find out that someone has already been transfused with the red blood cell, or someone has already been transfused with the platelets. So what we might recall is the plasma, or everything has already been transfused. But I'm trying to say that to make sure that we detect that and trap it on time, we can use this technology, okay? So this technology helps us to be able to look at that. Now, there's also what we call 3G printing of organ and blood vessels. I think this is still a new thing, and it has come across a number of things, okay? So here, we now want to kind of produce a kind of artificial blood vessels in terms of blood donation. So that is what this is all about, okay? Now, still in the advancement, then we'll talk about smart blood bag and sensor. So there are blood bags that they are very smart. They have a sensor, okay? They can be able to detect anything that shouldn't really be there, as the case may be. Then it can sensor it and give you the alert so that you can be able to respond accordingly. Then we'll have mass spectrometry for blood typing. So this can also help in the blood typing. When I mean blood typing, like determining the blood group or maybe an antibody screening as well, okay? Now, and you look at hemovigilance system. This hemovigilance system, from the word, I'm not sure. Let me ask the question. Who knows what hemovigilance means on this when they talk about blood bank? I don't just want to say it. Does anyone know? If you know, you can pop it on a chat, or if you want to say something, you can say. Anyone?
I think it's monitoring the process from blood collection to where it's transfused to see if there is any violation.
Absolutely, absolutely. There no removal. I'm not adding anything. I'm not, removing anything from your answer. That is actually what it means. So now, because I use the word system, because there's a system of going about it. This will help us to track any problem where possible. That way we can take up a report, of if there's any problem, why did that problem occur? If there's no problem, okay, that means what we're doing is okay. But if problem is occurring in certain aspect, then there can be a new guideline. Remember what I mentioned about MHRA, there can be a guideline, try to see where the changes can, affect, to make sure we have effective blood transfusion. And this is also might lead me to what we call, I don't have it here, what we call cold chain. So if you go for interview, they say, what is cold chain? Cold chain talks about the temperature, maintaining the temperature, maybe from the manufacturer to wherever and when that product is being used up. On this occasion, red blood cell or platelet or FFP or cryo, okay? So maintaining its blood temperature, from when it's being produced to when it's being transfused into a patient, okay? Now, to mention this as well, there's something I would like to tell you. If you collect blood as a whole blood, the temperature might be the same. But when you collect blood into different components, you realize that the temperature might be different, okay? For example, red blood cell, you can store it maybe between 2 to 8 degrees or 2 to 6 degrees. Now, when you talk about something like platelet, it has to be do with the room temperature. Maybe you're looking at something like 20 to 22 degrees. And of course, that of the cryo, you're looking at maybe something like minus 30 or minus 20, as the case may be, okay? So that is why it's very, very good. Then we have mobile application for donor engagement. So we also have this automated way of engaging with the donor. So these are some of the advancements we have here. And of course, artificial intelligence, which is AI, is a ruling thing now. Even as a lecturer, that's what students used to write now. Fair enough, that's okay. So this artificial intelligence can actually help for, blood screening as well. And then we also look at genomic editing blood diseases. So this can also help to, edit, the genetic constituents, wherever possible, of any disease, making sure that that will not necessarily affect that blood product. Now, there's what we call intrauterine blood transfusion. Intrauterine blood transfusion talks about, a baby in the uterus need red cells to be able to survive. So what happened that if there is hemolysis, time will fail me to explain the background, but if there's any hemolysis or maybe there's anything, meaning that the blood in the uterus is not really enough or whatever is not supporting the baby. Now, while the baby is still in the uterus, we can actually transfuse blood. We can actually transfuse the patient while in the uterus, so the baby while still in the uterus, and that is called intrauterine blood transfusion. So that is also another technology that is also useful. Now, of course, there's also another technology where when we identify any particular antibody, we can also quantify that antibody. In quantification of that very antibody, this can be very common in pregnancy. For some of you that may be coming for, sometimes you get interview question, they may ask you if a woman is pregnant and has whatever antibodies, what are you going to do? You have to quantify it, okay? So depending on the value that you get, you might decide, okay, let us, continue repeating this test, or as the case may be, the outcome of that result will determine the approach that the doctor is going to use. But what I want to explain is that there's a need to quantify IgG antibodies if it is a pregnant woman. Now, we have what we call antigen K negative. Now, this is also another technology where, should I really say technology? This is more of a guideline where we make sure that any woman within childbearing age is given antigen K negative, okay? Remember, I've talked about different antigens, maybe antigen D, antigen K, antigen E, antigen little c, many of them, Duffy A and B. Now, who knows why? There is a reason why I ask questions. Whenever it's sensitive, I want to ask questions just to make sure if I give the answer, you guys will remember it. Who knows why we would have to give, or it is recommended for us to give a pregnant woman or any woman within childbearing age to give them antigen K negative blood anytime they require blood? Who knows why? No answer. Okay, that's fine. I'm going to tell you. So now, all the antibodies are going to cause hemolysis. In fact, saying this now, let me say something. When you talk about antibody A, antibody B, or antigen A or antigen B. These are IgM I've mentioned it. So these IgM antigens or antibodies can cause what we call intravascular hemolysis. Well, it means that if you make mistake with ABO compatibility, that person may likely to die. But someone may not necessarily, you might be unlucky for someone to die because of IgG antibody or antigen incompatibility. But there's a problem with K. With K, while other IgG antigens or antibodies may cause extravascular hemolysis. So I've said the other one causes intravascular. This one causes extravascular hemolysis. But with the with the antigen K, if a pregnant woman develops antibody K, if that antibody passes to the baby, okay, now there's going to be hemolysis. The problem with the hemolysis it will cause to that baby is that it's going to affect the baby's bone marrow, and that may affect the baby's blood cell production. And that is why we want to avoid it where possible. That's why we constantly give antigen K negative. Now, there's what we call irradiated blood product. Irradiated blood product is where we can pass blood into a radio light, and this radio light will then kill any possible, substances, especially in fact when you talk about white blood cells. Remember, when you centrifuge your blood, you have plasma, you have platelets. When you are picking the platelet by your manual techniques, if you are picking platelet, you are likely to touch the white cells. So when we produce platelet, even with the red blood cell, there can be some white blood cell floating there. Are you following? And because of that white cell floating there, especially things like lymphocytes, it is not very good for immunocompromised patient, because things like lymphocytes, so once an immunocompromised patient receives blood, once every blood is transfused, you are likely to, white cell is likely to be introduced. The problem with that is the person is immunocompromised, that thing will technically cause a problem in future, which I may not have time to explain. But when we talk about irradiated blood product, we now use radio light to kill that cells, to take away that very human leukocytic antigen, which we call HLA. So once we take care of it that way, the person who is immunocompromised can benefit from that blood product. So this is what I'm trying to talk about, human leukocytic antigen. And of course, if the person is immunocompromised, where possible, because we may not be able to take away all the leukocytes, what we then do is to do what we call HLA match. We'll now match it to make sure it's compatible first. Then, of course, then we'll talk about the antigen, whether it is positive or negative. I've mentioned apheresis platelets. And of course, hemoglobin S is for people who are, sickle cell. Now, another thing I want to explain here is what we call high titer negative. This is another technology that I feel I like here. Remember that someone who is blood group A has antibody B. Someone who is blood group B has antibody A, right? Someone who is blood group A has antibody A and B. It is only blood group AB that does not have any of this antibody. Therefore, I know we said that blood group O is a universal donor, but that is not really true. Blood group O is only a universal donor on red blood cells. Blood group O is not a universal donor on platelet, is not a universal donor on FFP, is not a universal donor on cryoprecipitate, because it has to do with the plasma. The plasma is where the antibodies are, while the the red cells is where the antigens are, okay? So now, if that is the case, blood group O is only a universal donor when you talk about red blood cell, because it doesn't have antigen A or antigen B. But then blood group AB would then have to be a universal donor when you talk about platelet, FFP, and cryo. And that can alternate. What it means that if blood group O is a universal donor in red cells, it cannot be a universal recipient. But it can then be a universal recipient in FFP, cryo, and platelet. While if blood group AB is a universal donor in FFP, cryo, and platelet, it cannot be a universal recipient there, okay? But it can be a universal recipient in red blood cells. So that's how it works. So with the high titer negative, what we do is that because of the percentage of people that has this blood group AB is not much, then we are stuck. If we want to give platelet or FFP or cryo, what are we going to do? Because there's a possibility of not getting, what you are looking for. Then we now employ a technology of diluting this antibody. What is that? When we get blood group A platelet, we'll dilute the antibody B. So when we dilute the antibody B to what you guys call in microbiology MIC, minimum inhibitory concentration. So once we dilute it to the minimum concentration that it cannot cause an effect, we now call it high titer negative. So once any platelet or FFP or cryo is high titer negative, it technically means it now mimic blood group AB. Okay, so that's the technology that we use here. There's also what we call blood exchange transfusion and plasma exchange transfusion. Now, let me just show you about this 3D quickly video. I hope that we should be rounding up. So just a technology that shows, okay, how, these blood vessels can be manufactured artificially for blood transfusion, okay? Now, I'll just show us something here, just for example. This is actually where I would like you guys to pay attention. Who can tell me what this blood group is? Just type it on a chart. This is not a technical example. I've finished the presentation. I just want to show you guys how things work here, and then that is it. Does anyone know the blood group of this patient? Right. When the cells are down, it's negative. When the cells are up, it's positive. Okay. So basically, if I want you to look at this as your tie group, just forget about the control. Control should be negative. So what you need to ask yourself, so if I do tie grouping and there's no reaction in A, there's no reaction in B, but there's reaction in D, what blood group will you call it? Is O, right? And that now, if you look at the reverse group, it confirmed it because it has antibody A and B. Okay. Now, there's another thing I want to show us here. This is very, very important. If you look at this is what we call ABO compatibility. Because of our time, I'm going to just go ahead and explain this. When you see, you can see that the cells is up. There's cells up here. There's also cells down. That means it's negative and it's also positive. This can happen. This is what we call dual population. DUAL population. So dual population. So once you have a dual population, it means that this patient has been exposed to another blood group that is not its own. Let me explain it like this. So if someone is blood group O negative and you give the person blood group O positive, because you've exposed the person to D antigen, not on this occasion, okay? Because you've exposed the person with D antigen, what the person is going to have dual population, D antigen negative of the patient, and D antigen positive of that blood that person received. Now, if you look at this one, you're going to see the dual population here means that this person may be, okay, has been received a blood that is either B positive or B negative, depending, okay? But because you can see when the cell that is down here means that the person doesn't have the this person have received a blood that is either B positive or B negative. So the cell that is down means is B negative, but the cell that is high here means that it is what? B positive. I don't know if that makes sense, okay? Now, because the D antigen here, the D antigen means the positive or negative. Now, let's forget about the one that is up. If we go by this and forget about the reverse, if you go by this, you say that this person is what? B positive. If you forget about the up one, sorry. If you forget about the down one, sorry, you say that this person is B positive, okay? But because of this down one, it means that this person have received another type of blood. Now, I presented this because this is a case of transfusion reaction. This person is actually O positive. Is this patient here? And they gave this person B positive blood. Are you following? And that is why you're having this dual population here. Okay, so that is what we mean by dual population. So if you go for interview here and they show you this kind of thing, think about discrepancy. Maybe someone who have been transfused in the past. But the common one they're going to give you may not be in a case of transfusion reaction. It might be in a case where someone is blood group O negative and the person receives O positive. Does that make sense? Okay, so that is what they are likely to give you here. Now, let me also say this quickly. This is a guideline that shows you what we do here. So if we do a blood group and we notice blood group and antibody screening and the D reaction is weak, we can now decide, is it partial D or weak D, like I've explained. So if we now determine, that is how we can now go. So once we look at the result, you now say, is the reaction grade with one or more anti-D reaction positive but weak? If it is weak, if the answer is yes, the next question you ask yourself, what is the age of the woman? If the woman is less than or equal to 50 years, so if it is no, if it is not this age, if it is no, you don't need to worry, because what you mean that the person is possibly not going to give birth. Okay, so you are not worried about it. We are worried about weak D and partial D in a case of pregnancy. But if the answer is yes, we then need to investigate it further to make sure that the person is either weak D or partial D. Now, what we do is that if the result come back and say is a partial D, we'll treat the person as negative, not positive. Does that make sense? Okay. Now, this is talked about what we call enzyme panel. Is another technology where we identify antibodies using what we call enzyme panel. Enzyme panel means that they are treated with enzyme, okay? So it can help to be able to identify certain kind of antibody. So I'm going to show you the antibody panel, but what I'm trying to show you here is that there are some antigens or antibody that can be destroyed by enzyme. So those antigen or antibody that can be destroyed by enzyme are what we call this MNS and FYB. FYA and FY. So these ones can be destroyed by enzyme panel, that's enzyme treated, but it can enhance this. So enzyme panel or enzyme treated panel can either enhance certain antibodies or destroy certain antibody. In destroying antibody, these are the ones it will destroy. To enhance, these are the ones it will enhance. This helps us for confirmation of any of the antibodies we get. And there's also another thing we call dosage effect. You know about the competition of different antibody competing to a binding site. So that is called a dosage effect. We also consider that in a case of blood antibody identification. Because of our time, I'm not going to spend more time on that. Now, let me give you this example. So this is gene, this is the antigen. So this is JKA. Because it is only JKA, you can see that's the color, you can see it. So they can easily bind. So in this situation, you're going to get a strong reaction because there's no competition here. But look at here, you have blue and pink, I think so. Now, when you look at this, you're going to see that it's JKA and JKB. Because of this, the same family, okay? But there's a difference because one is A, the other one is B. There can be competition. Now, this competition can lead to either weak reaction or in some cases, it might be negative. And that is why it's also important you consider that in your antibody identification. And of course, this is also only JKB as well. Now, that means that this can give you the strength of the reaction where there is a competition. Like I've just shown you now, you might get +1 or you might even get negative. So you need to be careful that is negative. You need to work out, what is happening. Is it homozygous antibody or heterozygous, which I may not be able to explain more. But where it is homozygous antibody, you are going to get a strong reaction, okay? Now, let me show you this antibody panel, okay? So I'm just going to make this quick. So this is the result. So you've done the antibody screening, is positive. You now need to know the antibody panel. What is the exact antibody that this person has got? So this is a reaction. This is a reaction. This is a result you got from the patient. So the manufacturer has given you cell 1. Look at the cell here. Cell 1, cell 2, cell 3, cell 4, up to 10. Okay, I may not be able to have time to explain this R1. I have videos on all of this, okay? So, but this is the reaction. So what you are trying to do here is to see, look at this is a reaction pattern of M. This is a reaction pattern of N. This is a reaction pattern of S. So these are different IgG antigen I was talking about, by the way. So they are different reaction pattern. So you are trying to find out which of this reaction pattern matches this patient result. Anyone that matches it is the antibody that patient has got. Because of our time, I'm just going to go quickly to show you the answer. So this person has got antibody FYA. So if you look at the reaction pattern, on cell 1 is 0, 0, plus 4 means 1, 2, 3, 4, as the case may be 5. Even weak is also positive. So positive, positive, negative, 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 positive, positive, negative, negative, positive, 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 then negative, negative. That is how you can say this person has antibody Dufi A and B. Now, sorry, Dufi A. Now, because of our time, I may not be able to explain this much, but there is what we call dosage effect, like I've explained. We need to consider that. That will explain why we cross this off here. So but I may not be able to explain that. But let me show you something, just to give you a hint. So when we talk about the group, big K and small k, they're in one group. LUEA and LUB, one group. FYA, FYB, one group. JK, JKB, one group. Now, M and N, one group. That's the only one that is confused, M and N, because it's a different letter. But big S and small s, one group. Now, what you want to do is this. The homozygous, now we cross it where it is homozygous positive and the result is negative is where you're supposed to exclude that is not that antibody, okay? So if you look at this M and S, big S, sorry, S, this S and S. So big S is negative, but small s is positive. What it means that on cell 1, small s is homozygous. I just want to give us an example. But assuming that it is positive here as well, assuming this is positive, what it means that it will be heterozygous. So what we are saying, the rules say that if it is heterozygous positive here, even if it is negative here, because of the tendency of weak reaction or negative, you don't exclude it where it is heterozygous positive, even though the result is negative. Now, the rule says if the reaction is positive and the patient result is negative, exclude that antibody. But you can't exclude it if it is heterozygous positive. Now, these just other techniques like elution techniques where we think there's a kind of complement or any autoantibody that may be interfering with the result. We can use elution technique to remove those antibodies. Then that way we can be able to get the result we want to get. Remember somebody mentioned about medicine affecting the blood group. Yes, when that happens, we can use some of these techniques to be able to remove that interference. That way it can help us to get the result we want. So blood transfusion, like I've explained, is important. Then the testing in blood bank, ABO, antibody, Clahauer's, phenotyping, and all of that. Then we use automation. Of course, there are requirements, okay, like treated, like irradiated blood. Some patients need irradiated blood if they are immunocompromised patient. Some people require HLA match and so on. And of course, I've mentioned something like high titer negative. And there are guidelines that is guiding the blood bank, like, okay, I've mentioned current group, historic group, and I've mentioned something about why we give a pregnant woman antigen K negative. These are all guidelines. There's a number of guidelines, and I have videos on all of that. Anyway, thank you so much for listening. I don't want to take us more. I don't know if there's any question. Thank you.
Thank you so much, Dr. Bodo. This has been a very extensive cover of this topic. I know if you had more time, you would have still said much more. A lot of time has already been spent, so let's quickly look at if we have just a few questions. So please, you can drop your questions. I know some people drop questions at the very beginning and they are far away now, but yes, there's a lot of positive reviews too. This is mind-blowing, wonderful presentation and all that. So we can have your questions even.
Obina, can I also say, if they think that the time is an issue, what we can do is, I think many of them, if they get me on LinkedIn and they say, oh, I participated in this meeting, please, I have this question, I'm more than happy to answer it if nobody wants to ask the question here anyway.
Right. So I guess we heard that Dr. Emmanuel is on LinkedIn. You can get him on LinkedIn, Dr. Emmanuel Obodo. So you can get him on LinkedIn and then perhaps ask your questions there. Okay, I've not seen any question here. The only one here is, if blood components separated, can it affect the lifespan of the blood? That's one of the only questions here. If blood components is separated, can it affect the lifespan of the blood?
Not really. Just 1 minute. Another thing I try to do with you guys is that I've popped on a chart. I should actually say YouTube. Just 1 minute. YouTube channel. I just want to make sure some of the things I've said. If you can actually go on my YouTube channel, you see a lot of things there, and that will really help you a lot. That will really help you a lot. Okay. Anyway, so Obina, you were asking a question. Sorry, I didn't get that.
Okay, so somebody was, yeah, I think you answered that already. If blood component when separated can affect the lifespan of the blood.
Okay. I think depending on how you look at it, the answer is yes, isn't it? Because if the red blood cell lifespan in terms of maybe, I don't know, how will I put it? Technically your blood's supposed to be 120 days, but once it's collected in a bag, it has a certain kind of life, shelf life, okay? But you can see that the variation of the shelf life is dependent on the component. Something like platelet is just for 5 days, okay? Something like red cells can take a little bit longer. Something like FFP and cry can take some years to be able to expire. Yes, if it is types of life shelf, the different components have different life shelf.
Okay. Yeah, thank you for that.
Yeah, I've already, sorry, someone was asking me something. I've already put my YouTube channel. They just called Too Good BMS. I think so. Sometimes I forget. Too Good BMS Jobs. Okay, so it's my YouTube channel. Just if you search it, yeah, you will see a lot of this information, and then that should be okay. All right. Any other question?
So, Mr. Aliyu, your question is not clear. Why is it just for 5
Yeah,
days?
I think I understand. She's asking about platelet, isn't it? Why is it just 5 days, isn't it? I think that's what the question is. Yes, that's what the question is. So it's because, the nature of the platelet, it can easily denature. Remember, it's a protein. Remember. In fact, let me even say this. When we collect platelet, we need to put platelet in agitator. If we don't agitate platelet, if you don't continue mixing the platelet, in the agitator, what is going to happen? It will be activated and it will form a clot. It will clot, basically, okay? Now, that is why it needs to be agitated. And because of is a protein and is likely to denature under that room temperature, you can't really keep it for a long time. Okay, I hope I've answered that question. And there's a question I would have said, yes. Head and that's that is actually the main cause of it. And of course, sorry, 1 minute. Can this antigen K negative be used to? It depends on how you want to answer that question. So we give antigen K negative to prevent the possibility of that HDN. Okay, that's to prevent it. But it doesn't entirely prevent it, because even if you avoid antigen K, anti-D can also do the same thing. And the only thing is that we want to affect HDN caused by antigen K because of the possibility of affecting the bone marrow of the baby. I was going to say something quickly from what somebody just asked. Maybe what I should actually expect you guys to ask me is, why are we talking about antibodies on platelet? Platelet is just a thrombocyte. We shouldn't really be talking about antibodies on platelet. We shouldn't be worried about it. We shouldn't be worried about antibody A, antibody B. We shouldn't, because it's a cell. If we can't worry about if the antibody should be in the plasma, not on the cell. What's supposed to be on the cell is antigen, not antibody. So why, if platelet, which is a thrombocyte, is a cell, why are we worried about anti-A or anti-B, leading to maybe high titer negative, as the case may be? Now, the answer to that is that because of the question someone asked that reminded me this. So because of the nature of the platelet, it can easily deteriorate. It can easily be activated. So what we do is to mix it with plasma. So we talk about your plasma, you mix it with plasma with the platelet. That can help the agitation, so it can be flowing, because you cannot agitate a cell. You need that liquid portion of the blood to help you to be agitating the cell, and so on. So that's actually, because of that plasma will add to it, that's why we now talk about the antibody. Apart from it, we shouldn't really be talking about that. There are so many things I want to say now, but time wouldn't let me to say that. Somebody else say I'm not sure if I've lost a track. Obina, I think the question is going up. I'm missing some of them, so I don't want to read some and leave some. Thank you for the compliment. I think there are some questions I missed while I was talking, and I'm not
Yes,
sure.
one just said, is it possible to get panel of cells commercially?
Yeah, the cells are commercially prepared. The antibody cells are commercially, the antibody panels cells, they are commercially prepared. Okay, if you buy it and buy IgG card, it's something that people can actually do in Nigeria. You can do it manually. Don't necessarily need the automation. even this IgG card and even the ABO card group, if you buy the card, you can actually do it, manually. That an analyzer can do, you can do it. All you need to do is just dilute the cells, make the opening, you can peel it off. You don't need to make opening like analyzer. Just peel it off. It will be open. Just add whatever you want to add. Put it in your incubator, centrifuge it. It will give you the answer.
Okay. Well, thank you, Dr. Emmanuel. Okay, so let me just take this last one. Please, sir, how do we get screening cells R1, R1, and R2?
Like I said, if you mean how to get it, like buy it, it's commercially done.
Okay. All right. So we would want to draw the curtain here. Thank you very much, Dr. Obodo. Sincerely, I know that there's much more.
Just Obina, let me answer. There's a question that came. I think is an interesting question. How can cryoprecipitate be extracted? This is very, very important question. Okay. Even though I may not give you detail because of our time, but I want you to know that for clots to form, fibrinogen needs to be converted to fibrin. So what happens is that when the plasma, in that plasma, there are clotting factors in which fibrinogen is one of the clotting factors. So what is going to happen is that what they will do, once they've removed a lot of the plasma, okay, or they will just put the plasma in a freezer, a more lower temperature. Now, if you look at blood when it's the lowest, you're going to see whitish substances. That whitish substances you are seeing, they are fibrinogen. So because that whitish substance is not, like when you have a proteinous substance like a milk, I'm not sure how to explain, you see some whitish substance sedimenting at the bottom. That is, in terms of plasma, that will be fibrinogen. Okay, so what they will now do, they will now remove the plasma and leave that bottom part. You see, now they remove majority of the plasma and leave less plasma with more of that bottom part, which is now the fibrinogen, and that is now called cryoprecipitate. All right, okay, that's fine. Obina, go on. I think that's where I'm going to draw the curtain. Thank you. Thank you, everyone.
Okay, so I think some of the questions will still be trapped from Zoom, and we can still share them with you when we have them. Thank you very much, Dr. Obodo. This has been a very great time, and thank you, our participants, for being patient with us all through this learning period. Be sure that you're going to get the recordings, you're going to get the slides. Dr. Obodo will graciously share them with us, and then you would get the certificate of attendance or participation for this webinar. Thank you so very much. Do have a very good night rest, everybody. Thank you, Help Desk.
All right. Thank you so much. Good night. Bye.
Night. Yeah.